Hello, welcome to Yashoda Hospitals. I'm Anusha, hosting nursing education and training webinar series in live and Facebook every Thursday at 3 p.m., bringing forth the most interesting topics. Thank you everyone for joining us today. Stay tuned till the end of our expert discussion, and also you can post your queries in the chat box, which will be addressed at the end of the webinar. So our topic for today is nutritional management in preterm babies in NICU. So without further delay, let me introduce you to our pros of the today's session. I would like to introduce our expert panelist, Dr. Srinivas, consultant pediatrician at Yashoda Hospitals, Malakpet. I also would like to introduce our speaker for today, Ms. Nirmala, nurse manager at Pediatric and Neonatal ICU in Yashoda Hospitals, Malakpet. So I would like to, looking forward for enlightening the session, I request Ms. Nirmala to start the session.
Good evening, everyone. Myself, Nirmala. I'm in charge of NICU PICU from Somajigoda. Last what we have discussed about preterm baby, subcategories of in preterm births. We have discussed last week. Today topic is nutritional management in preterm babies. We are going to discuss about nutritional to preterm infant indications, feeding methods for preterm baby, recommended enteral and parenteral nutrients values, nursing awareness. Optimal nutrition is highly essential for growth and development of the preterm baby and also metabolism and immunity for preterm babies. Minimal enteral nutrition, it is also called gut priming. Trophic feeding for preterm babies is 10 ml per kg per day. The standard target of feeding volume is 150 to 160 ml per kg per day. Guidelines for the enteral feeding, according to birth weight, we can take initial volume of the feeding less than 1000 grams, 10 ml per kg per day, 1000 to 1500 grams, 20 ml per kg per day.
One moment now.
Minimal enteral nutrition, 1500 to 1800 grams, 30 ml per kg per day. 1800 to 2500 grams, 30 to 40 ml per kg per day. According to guidelines, they have given here volume increases every 12 hourly. But in our hospital, day by day, we can increase the volume. Regular assessment for identification of the preterm babies for feeding intolerance, particularly in high-risk babies. If feeding is contraindicated or feeding intolerance, colostrum should be applied as a mouth care. Here we can see some colors: milk, lemon, mustard, wasabi, lime, avocado, spinach. If baby is aspiration and vomiting, color will be milk and lemon. It will be normal color. Mustard and wasabi, lime. These three colors we can take it is normal, but if there is no other indications. Other indications means abdominal distension and tenderness and dullness of the baby. Then remaining avocado and spinach. These colors means green color. So dark green. If baby is vomiting, green color, and aspirations will be green color, indication for the intestinal obstruction. Need to assessment regularly. Feeding methods, enteral feeding and parenteral nutrition. Enteral feeding will be breastfeeding, formula feed, nasogastric feed. Once the baby has developed sucking and swallowing, coordination will be there. We can encourage the mother to give breastfeed. In some cases, the expressed breast milk also can be given to the baby once the baby is ready for gavage or breast bottle feed. But most of the parents, they have great desire to give feed by themselves their babies to enhance the mother and child bonding process. Once the premature baby is stable enough to receive feeding through the gut, we can give the gavage or NG feeds, a small tube inserted through the nose or mouth directly into the stomach, and a small amount of expressed breast milk and formula feed can be given to the baby. If baby is tolerating well, we can gradually increase the feed. Recommended enteral nutrients. So nutrients according to baby weight. Here we can see fluid, energy, protein, fat, carbohydrates, calcium, phosphate, vitamin D, vitamin A, iron. These nutrients we can see in the formula feed. Recommended feeding schedules, fluid and feeds. And according to baby weight and according to day of life, we can take for term babies starting at 60 ml per kg per day, and for preterm babies 80 ml per kg per day. For sick babies 70 ml per kg per day we can take. Day by day we can increase the 20 ml for preterm babies and term babies. A target feed is for term babies 140 to 150 ml per kg per day. For preterm babies, target feed is 160 to 180 ml per kg per day. For sick babies, 110 to 120 ml per kg per day. If baby is tolerating well, we can increase the day by day 20 ml for term and preterm. For sick babies, 10 ml, we can increase the day by day. TPN is a method of feeding that bypasses the GI tract. Also, it administered through intravenously. TPN provides all requirement nutrients to the baby. Components of the TPN: fluids, electrolytes, sugar, lipids, amino acids, and vitamins. Amino acids and lipids can be given 1 to 3 grams per kg per day. Here, common components, requirement components can be given. You can see here, if anybody wants to take the screenshot. TPN, when to stop the TPN and why to stop the TPN. For babies born before 28 weeks, once the enteral feed volume is reached 140 to 150 ml per kg per day, we can consider the stop the TPN. For preterm babies born after 28 weeks, once the enteral feed volume is reached 120 to 140 ml per kg per day, we can consider stopping the TPN. Although even the most premature baby gut is capable of accepting and digesting the milk, sometimes the baby may be too unwell to take the feed. That time we can give the TPN through intravenously. TPN can also provide all the requirement nutrients to the baby. Nursing awareness. Do not start the feeding if we are not confident feeding tube is in the correct position. We do not give the feed. Before giving the feed, we have to check the NG feed, ROG or NG. We can check the before giving the feed. If we are not confident it is in the stomach, we do not give the feed. Baby is having in distress, breathing problem, crying or in pain also, we cannot give the feed. When we have to remove the NG tube, while the baby coughing, choking is nothing but breathing difficulty, gasping and cyanotic, unable to speak. In these conditions, we can remove the NG feed. This is the top. Thank you.
You have to unmute, Anusha. You have to unmute and they're not able to hear.
Thank you, Nirmala. The panel is now open for discussion. I request the participants to post their queries in the chat box so that our expert panelists will be answering your queries. So we have a question here, sir. Srinivas, sir, the question is, if the baby has not improving the weight even after parenteral nutrition, what measures should be taken by the nurse? So please unmute.
So the most important thing is you have to calculate according to the weight, how much of the volume is going or not. If you're giving the correct volume required for that age and the weight, you can see other factors. So most of the time what we see in our routine practice is skipping of the feeds or not giving the enough ml of the feed. Still, if the baby is not improving with the feeds, not enteral feeds, so you can go with your what do you call it, total parenteral nutrition. That is called, you put an IV line and you will start. So this all depends on the age and weight of the child. We cannot go like randomly to choose. Everything is like guideline based. So for if you ask me, like for a less than 28 weeker, it's better we start with total parental nutrition other than going with the enteral like gastric feeds or oral feeds, because the gut is not matured enough to take whatever the feeds we are giving. So it's better to give through the central line, that is called as total parental nutrition. If the baby is around 32 weeks, we generally go with your tube feeds, that is called orogastric feeds. You put a tube inside the tummy and then you start giving. If the baby is not improving weight with your feeds, you can fortify. You know that once the baby is reached enough full volume, like baby is tolerating the full volume, like it's target feeding around 150 to 160, then we fortify the milk. So human milk. So there the calorie count will be increased by giving a HMF. That is called human milk fortifiers. So that will increase the calorie and the baby can see the growth. Apart from this, you have to check whether the child is having any other losses, because the child might be sick in the sepsis or the child might have hypothermia. All these are the other causes to check whether the child is why the child is not improving in weight. Yeah.
So, and what are the common challenges we face, in improving the weight of these preterm babies?
That's right. See, as I keep saying, it all depends on the gestational age where the baby got come out from the mother. So if it is less than 28 weeks, if it is less than 30 weeks, and it is 32 and 34, because individually it is different. For less than 28 weeks, we can't even be, it's better to start with the IV line, that is we call as TPN. And from 30 to 32 weeks, we generally go with the with tube feeds, that is also called as orogastric feed. And from 32 to 34, we can give a spoon feeds like Paladay feeds. And after 34, you go with your breastfeeding. So the most important challenging what we see is that preterm, most of the time they are underweight, like extremely low birth weight, less than 1 kgs. And here the calculation, the most important is according to the weight, we have to calculate every day, because it's like a number game. Every day you have to keep changing according to the day of life, hours of life, the calorie requirement, your TPN calculation keeps changing. So, utmost nursing care is important while delivering this. Why? Because we are going through a IV, that is central line. TPN is the most common where you see a lot of infection, because lipids are the carrier for the lot of bacteria and all. So it's most important is your preparation of the TPNs are most important to prevent sepsis. And after that, mixing of the feeds, how you are going to mix the feed, what water you are using in the ICUs. So whether you are using the appropriate water to mix the formula feeds, if you are giving a formula feeds. And if you are maintaining the expressed the breast milk, so how the containers are there, how they are sterilizing. These are the most important things you have to take care from the nursing staff, because preterm care is not like a single person game. It is like a collective. It runs like whole team, the morning staff, the afternoon staff, and the night staff. Everyone should be aware of what we are doing for the child. So all together over a period of 30 to 50 days, if everyone works together with a good hygienic environment, then only the outcome will be good in NICU, especially in the preterms.
We have one more question, sir. So they're asking, some premature babies on total parental nutrition will go into electrolyte imbalances. What could be the reason?
Yeah, that's right. Again, the most important is fast infusion. First thing, you're just giving it the fast. And second is calculation. So based on the weight, the calculation should be good. It's always important to be supervised by the double checking. We call it as double checking. So it is always better to supervise when you're starting the TPNs. So that can prevent your electrolyte. But it's most common actually. That is the second thing you see in TPNs. So always put in mind to double check and calculate. As I said, it's a number game, because 800 gram, 900, 1 kg, 1 point. So all these babies are in number. So calculating according to the required calorie and required lipid, required protein, all should be done under supervision.
And is KMC useful to gain weight for premature babies?
Yes, absolutely. If you ask me, that is the most important thing which we have to encourage and practice, because not only gives a bonding between mother and child, it gives the warmth, it maintains the temperature for the baby, and it helps in the mother to secrete the milk. So KMC was the proven thing. The other thing which I missed in the previous question is, if the baby is not improving weight, KMC is the one which is going to help to increase in the weight. So practicing KMC is mandatory for all premature babies and low birth weight babies. So definitely it's going to helpful, and almost all institutes they practice KMC who are dealing with the preterm care.
Thank you, sir. Thank you for your answers. Can you give a take-home message for our nurses for
Yeah.
improved quality
As
care?
I said, like preterm care is always like a hard work. I can say like it was a multi people. All the people who are involved in the preterm should be from heart. I can say that, because we see that sepsis is most common in preterm deaths and all that can be prevented with a very good hand hygiene and maintaining the environment clean, which generally we miss is like preparation. I feel like preparation should be taken care by the nursing staff very well before, because once you're going near preterm baby, you should be very careful, because you never know which route we are giving infection, either through feeds or so. Preparation in the laminar flow, whatever the methods you are available in your setup, that is most important, and giving regular time. And the most important is identification of the risk factors. See, just if the doctor writes some medical feeds as we write trophic feeds or that is the initial feeds. So checking the signs of whether the child is tolerating the feed. So the most important is identifying the warning signs. Those are like, as we already discussed, vomiting, which is discoloration, greenish, as you said, greenish or red color, semi-red. All this where the child might be going into the NEC or intestinal obstruction. Identifying of that one. Second is distension of the abdomen. So if there is any distension of the abdomen or retention of the feeds after post-feed retention of the feeds, all these should be monitored. If you keep giving, if the early identification of NEC, because preterm, the problem is preterm, I say that they are the one, the mother won't get enough milk. So you may go sometimes with the prelactal feeds that may cause NEC. So identification of NEC early, what you do is you don't give enteral feeds. You stop feed, you give a gut rest. That will prevent the baby further not going into the further complications. So my take home message is always like when to give, what to give, and how to monitor while giving. As you said, like placing the NG tube, checking the NG tube, whether the NG tube is there in place every time. I keep saying this is every time before you're giving the feed. What happens is you put a NG tube or orogastric tube in the morning. After every 2 hours, you keep feeding, but sometimes the orogastric tube or NG tube might be replaced and went into the lung. And you push the milk, it may enter into the lung. So before every feed, try to check whether the NG tube is in place or not. And the last is identifying of the warning signs, whether the baby is going into NEC or not. Okay.
Thank you, sir. Thank you for your wonderful take-home message.
Sure.
I hope everybody enjoyed today's session. If you did, please do share our page on your social media. And we will meet in the next webinar on Thursday. And the topic will be on, it's an interesting thing. We will have a quiz on neonatal nursing on next Thursday. So we will definitely come up with the same. Stay tuned and keep smiling.
Thank you.